I'm Alex Shtilbans. I'm a movement disorder neurologist at HSS and also an assistant professor of neurology at Weill Cornell Neurology and Department. And so today I actually invited all of you to join to uh, hear the updates on new interesting medications for Parkinson's disease and hear about exciting new research that hopefully would lead to development on new medications for Parkinson's disease. So these are my disclosures. And the objectives today to talk about not just Parkinson's disease, we will be talking about essential tremor and dystonia as well, because I treat all movement disorders, not only Parkinson's disease. Believe it or not, Parkinson's disease is not the most common, movement disorder. The most common one is essential tremor. And then Parkinson's disease goes after that, because a lot of people have shaky hands. So we will talk about newly approved medications, and we're talking about over the last 5 years. Then we'll talk about drugs in development, promising clinical trials, obviously, and I will touch base specifically on the patient care models for Parkinson's disease. So with this said, without further ado, let's jump in Parkinson's disease. So we'll start with Parkinson's disease and then go through essential tremor drugs and dystonia drugs. So this slide shows what are the new drugs, so to speak. And these include Crexont, which is the long-acting levodopa, Inbrija, which is short-acting levodopa designed for rescue. It's inhaled version of levodopa designed for acute off episodes. Nourianz, which is adenosine A2A antagonist for wearing offs. Ongentys, long-acting CMT inhibitor for wearing offs. This is Vyalev, which is the subcutaneous infusion pump for motor fluctuations. And Gocovri, which is the long-acting amantadine used for dyskinesias. Nuplazid is medication as antipsychotic for hallucinations. We will not be talking about Gocovri or Nuplazid because they've been around for many years. And so the topic of this lecture is just to cover newer medications. And Gocovri is just a long-acting amantadine, nothing more. And amantadine also has been around for 50 or 60 years. Nuplazid has been around for 8 years. So it's antipsychotic medication and will not be covered today's lecture. Okay, so let's jump into the first one on the list that I just showed you. That's the Crexont, which is the carbidopa-levodopa extended release. And what it does basically, it combines immediate release granules and extended release pellets. And so if you look at hopefully you can see my mouse moving on the right portion of the screen. So you see that the immediate release granules depicted on the left part of the schematically represented capsule, also combined with the extended release pellets that occupy the majority of the space in that capsule. And they allow for very slow release of the levodopa. Now, this is a comparison in terms of the difference of technology in the regular carbidopa-levodopa. Rytary, you might have heard of Rytary. That's previously manufactured long-acting levodopa, and the newest version of it, which is called Crexont. It's the same company so Rytary is made by Amneal, and Crexont is actually made by the same company. So they just improved on Rytary essentially. And here you see that the immediate release does not have extended release component, whereas Rytary does. But the latest edition has mucoadhesive polymer technology, which allows for even longer duration of action. And let's demonstrate that. So this Crexont long-acting levodopa, this graph on the left side shows the different comparison between Crexont, which is the light blue, Rytary, dark blue, and a regular carbidopa-levodopa gray. And this is the plasma levels after administration of a single dose. So you see that the gray goes up and then comes down. Rytary goes up and stays longer. And Crexont, which is the one that we're discussing, it goes up and stays longer, even longer than Rytary. In fact, on the right side, you see the difference in the amount of time, how long Crexont lasts in terms of the plasma levels, comparing to Rytary and comparing to regular carbidopa-levodopa. So this is another graph showing the difference between the regular carbidopa-levodopa and Crexont. So people they were optimized at this point, And they were taking either immediate release carbidopa, levodopa. That's the lower line, and the top line is Crexont. So there was a half an hour increase in on time from Crexont, but not only that. You'll say, well, half an hour, what's the big deal? Look at how many times people are taking the medication. So carbidopa, levodopa 5 times a day, Crexont 3 times a day. So taking it 3 times a day, they still had half an hour more on time without troublesome dyskinesia. And then that was the secondary endpoint. That's a reduction in the off. The primary endpoint was increase in on time. That's another half hour. So half hour increase in on, half hour reduction in off, overall 1 hour improvement, but reduced dosing, right? So it's easier 3 times a day with meals. It's easier than 5 times a day. Okay, side effects is the same. It's exactly the same medication, just long acting. Okay, so then Inbrija. So I'm not going to dwell on one medication because we have a lot to cover. Inbrija, it's inhaled levodopa for off episodes, and it could be used in conjunction. In fact, it has to be used in conjunction with other levodopa, regular maintenance levodopa. Why? Because Inbrija does not have carbidopa. It only has levodopa. So it will not work unless you have carbidopa, levodopa on board already. And so what does it do? Essentially, you carry that kit, and if you're off suddenly, you can inhale it, and in 10 minutes, it gives you meaningful on time. So this slide shows the comparison between gray line is a regular carbidopa, levodopa. The blue line is Inbrija. So you see how it takes an hour for regular levodopa to get to this point, but the Inbrija inhaled version gets you up like in 10 minutes, and then it wears off. So it's only lasts 1 hour. So Inbrija, from word bridge, so to bridge the doses of maintenance carbidopa, levodopa together. So it's not designed to substitute it, but to complement it for those times, let's say in the morning, if you wake up with an empty tank of gas and you're feeling off, you can inhale levodopa, get on faster, and then take your regular levodopa anyways, and then you won't have this long off time. Now, so the onset of action, 10 minutes. In 30 minutes, people have significant improvement, and it lasts up to 60 minutes. And so that's been around for probably 5 or 6 years. And for people who have sudden offs, unpredictable offs, that could be useful for as a sort of rescue medication. Okay, the side effects. You're going to say, what are the side effects? I talked about side effects of Crexont. I said they're identical as carbidopa, levodopa. This is different. This is inhaled. So then all the inhalation-related side effects would be seen here. In fact, 15% of folks in clinical trials developed cough. It wasn't disabling cough, but it was cough, and versus 2% in placebo. And in fact, the older people over age of 70 had more cough than younger people for reasons we don't know, but that's the fact. And so the other thing, the nausea was slightly more than placebo, obviously, because it's levodopa. Sputum is discolored. It's like a black sputum. Some people reported, but it's not dangerous or anything. But cough would probably 15% would be the sort of the most common side effect. Okay, now Nourianz, you might have heard of, some of you might be taking Nourianz, which is adenosine A2A receptor antagonist. It's designed to extend duration of action. Most of these medications, so I already covered Crexont. The rest of them will be just enhancers. So what does it mean? You take it in addition to carbidopa, levodopa to make it last longer. And they can be combined. It's not like you have to take either one or another. They can be combined if needed. So, and could potentially combine with Crexont or Rytary or regular levodopa. So, now Nourianz had 4 clinical trials. These first 2 were the U.S. trials, and study 3 and 4 were done in Japan, where the medication was developed initially. And the blue bars represent 40 milligram dose. The green bars represent 20 milligram dose. The black bar represent placebo. And basically, the Y line represents the amount of hours in on time, above 0, and the off time below 0. So basically, what we're saying here is that study 1, there was a basically 1 hour increase in on time comparing to placebo, and like 1 hour reduction in off time comparing to placebo as well. So you see that the dose response was seen in study number 3. So the 40 milligrams were better than 20. In study number 2, these two were identical. They were two identical, 20 and 40 made no difference. I started using 20 because I felt there was much difference. But later, I started using 40 as well and realized in real life situation, 40 does make a difference. But 40 is associated with slightly high side effects. What are the side effects? Dyskinesias. 17% of folks on Nourianz develop dyskinesias. These are involuntary body movements, comparing to like 6% on placebo. So, and for 20 milligrams, the side effects essentially were indistinguishable from, well, there were still dyskinesias. Dyskinesias were seen, but there wasn't really anything else. Important thing to understand, this enhancer does not work as a monotherapy. So Crexont, you can take just Crexont, nothing else. But Nourianz, you have to take in addition to carbidopa, levodopa. Yeah, it does not work as a monotherapy. Just to bring this to your attention once again. Okay, and then next one, Ongentys. You might have heard of Ongentys. Let's just talk about chemistry here. So levodopa, right? Levodopa gets to the blood and it needs to get to the brain. So before it gets to the brain, it's being degraded by two enzymes. One is CMT, which is corticoamine monotransferase, for those who want to know, and the other DDC. So, and essentially what we need to do is to inhibit those two enzymes to prevent premature degradation of levodopa before it gets to the brain. Because once it's in the brain, it's being converted to dopamine, right? It's being converted to dopamine. And we'll talk about that conversion later when we talk about gene therapy, because there is another gene therapy that acts right here that helps conversion of levodopa to dopamine right here. There's that gene, we'll mention that. But just remember the diagram, we can look at it later. So what Ongentys does, it does not work in the brain, that in the periphery, it just inhibits the enzyme which is responsible for premature degeneration of levodopa and allows for more levodopa to get to the brain. And what does it translate into? Let's take a look. It translates into reduction in off time, 2 hours comparing to baseline or 1 hour comparing to placebo. Always look at placebo because placebo matters. And so, yeah, companies trying to sell you that information that kind of looks nice. It's 2 hours, but it's over baseline. The important thing, what's the difference from placebo? So difference from placebo, it's 1 hour reduction in off time. And 0.8 hours increase in on time without troublesome dyskinesia. That was the secondary endpoint in that study for 50 milligrams of Ongentys. It also comes as 25. So what are the side effects from Ongentys? Well, by itself, it doesn't do anything. If you don't take levodopa, you take that Ongentys, it will do nothing. No side effects. But if you take levodopa and Ongentys will enhance the action of levodopa. And essentially what it will do, it will cause all the side effects that you get from levodopa by the virtue of having more levodopa in your blood. So by itself, it has no side effects because all it does is just increase the amount of levodopa in the brain. So that the side effects of levodopa, those of you who are taking it know, it could be nausea, could be dizziness, could be lightheadedness or sleepiness. So these are potential side effects not directly related to that medication. And now, so yeah, that's for Ongentys essentially. That's the efficacy. You see that on average, you get really 1 extra hour comparing to placebo, no matter what I talk to, regarding what I talk about, whether it's the enhancers or Ongentys comparing to levodopa. Now, we will switch gears and talk about something that can give you a real boost. And that is subcutaneous levodopa pump. So we've been waiting for this for years and years and years. So there were 2 levodopa companies that they were making these pumps, and they were both rejected a year ago. They resubmitted, and one company got approved literally 1 month ago. So I haven't seen that pump. It's not available yet, to my knowledge. It's called Vyalev, which is the combination of phos-carbidopa and phos-levodopa. These are prodrugs, and they are packed in the pump depicted on this diagram, and that pump is attached to your belt, and then there are little tubes, camels, and they're attached to the stickers, and these stickers get attached to your skin, and they have microneedles. So for these microneedles, the carbidopa, levodopa being infused continuously under your skin and provide the continuous level of carbidopa, levodopa in your blood. So this would be instead of levodopa. You don't need to take carbidopa, levodopa at all by mouth. You will be only taking that. And why do you need it as opposed to the pills? If the pills are not good enough, if despite all these enhancers that I just described, you combine them all and you still have wearing offs, you can use carbidopa, levodopa, and look how many hours it gives you. 2.7 whopping hours increase in on time comparing to baseline, or approximately 2 hours, better than the regular carbidopa, levodopa. So it provides a constant infusion. There are some technical issues that you need to get educated how to reload that pump. I would be adjusting the rate of infusion for this pump, and it would be covered by insurance. But as I said, it was approved literally 1 month ago. It's not available yet in pharmacies. When it is, I'll let you know, of course. I have several patients who've been waiting for this. And, so that definitely could be helpful for those patients with very advanced Parkinson's disease. So that's the update on that. It's officially approved. The second company is not approved yet, but the first one called Abvi. You might have heard that company called Abvi. Same company, they purchased Botox. So Botox now belongs to the same company called Abvi. Now, so we talked about Crexont, we talked about Inbrija, Nourianz, Ongentys, Vyalev, which is the pump. We did not talk about Guacavri because it's a long-acting amantadine for dyskinesias. We did not talk about Nuplazid for hallucinations. Those people who have hallucinations, these are not old medications. They are not new medications anymore. Okay, now we'll switch gears and talk about DBS. Why? Because I'm getting a lot of requests from people to briefly at least mention about DBS, because it's another therapy that's evolving. And we will talk about MRI-guided ultrasound, which is the sort of a latest addition to sort of a surgical treatment of Parkinson's disease symptoms. So deep brain stimulation surgery is a surgical treatment. It's not a cure. And basically, as the picture shows, it involves placement of the 2 electrodes, or 1 electrode. We can do it on one side only, in the deep portion of the brain. The electrodes are connected through the wires to the battery, called like a pacemaker. And this battery can provide continuous stimulation of the deep portion of the brain that results in complete dissolution of the tremor, so tremor goes away, and improvement in motor symptoms. So the wearing offs improve, dyskinesias improve, but tremor is really most dramatic because none of the medications can make the tremor go away entirely. And so we don't chase the tremor with medications. They are increasing the dose just for the sake of the tremor. So if it's disabling, DBS would be the godsend because it will make it go away entirely. And so that's what the battery looks like. And the different options now. You can get rechargeable battery like Tesla that would last 10 years or 15 years. You can get a regular one that lasts 4 years. So there are different versions of that. And who are the good candidates from Parkinson's disease? By the way, the DBS is used not only for Parkinson, but also used for benign essential tremor and for bad dystonias. So it's still different portion of the brains are targeted, but it's still used for other conditions as well. So you need to have, let's say, talk about Parkinson's disease now. Clear diagnosis of idiopathic Parkinson's disease. Why? Because they've tried it on other variants of Parkinsonism, such as multiple system atrophy, corticobasal degeneration, or progressive supranuclear palsy, and it actually doesn't do anything at all. So we need to make sure this is just a regular Parkinson's disease. And people have demonstrated good response to carbidopa, levodopa in terms of stiffness and slowness, but let's say they have poorly controlled tremor, or the medication doesn't last long enough, and so then we know for sure that DBS would help. The issues that they're suffering with, like disabling tremors, for instance. So then people have to be in stable cognition, because if someone has dementia, if someone has cognitive issues and they do DBS, the dementia gets much, much worse. So in fact, everybody has to go through the neuropsychological testing prior to the DBS surgery. And if they fail, then we are not going to do DBS because the dementia will just get worse. So then tremor, we talked about realistic expectations and good family support. Why? Because I had some patients who were referred to me, they received already DBS, and they were misinformed, so they claim, that the DBS is a cure for Parkinson's. So once they have DBS, nothing else is needed, which is not true. people do need to take their medications, but they can reduce the dose by an average 25%. They'll take slightly less, and the tremor is gone. But other things, the DBS doesn't help. So, and we'll talk about what it helps with. And I already mentioned tremor, wearing off, dyskinesias. So when is the good time to do DBS? So DBS could be done in the right window of opportunity, so to speak. So if someone has a flicker of the finger and I diagnose them with Parkinson's disease, they don't need DBS. They don't need any medications. Let's say disease progresses and they have a little bit of stiffness. I give them the medication and they're perfect. They're fine. They don't need a surgery. Then time comes, the tremor gets worse and the medications don't control the tremor anymore. So then it's the time to do DBS. Or let's say someone didn't do DBS for one reason or another. They're coming to me in a wheelchair. They've had Parkinson's for 25 years. They have a little bit of tremor. They cannot walk. The DBS is not going to do anything. So it's kind of missed opportunity because I know that 15 years ago, they could have benefited from it. So it's already kind of the past window. So you really need to do it in the right time. So not in the very, very beginning and not when you're already kind of in a wheelchair because you are not going to benefit from it. So improvement from DBS expected in the following conditions. Tremor, as I mentioned, dystonia, slowness, stiffness, freezing, but not poor balance. So poor balance doesn't get better. Involuntary body movements, then wearing off. So DBS can add 4 to 5 hours of on time without troublesome dyskinesia to your day. So it's probably the most powerful treatment in terms of improvement on your on time. And you can reduce the dose of levodopa by 25%, depending on what target of the brain surgeon uses. And then the other expectations, realistic expectations of what's not going to get better. Speech, some people with Parkinson have slurred speech and quiet speech. It's not going to get better from that surgery. Then balance is not going to get better. Memory is not going to get better. And autonomic nervous system issues such as drops in blood pressure is not going to get better from the surgery. So knowing that, if you need to be going for that surgery, knowing what to expect, because you have to be on the same page with the doctor. Okay, so the complications. So these are all listed complications. The usually people tolerate it beautifully. I mean, I really haven't seen a single complication in probably 15 years, but they've been reported. So if you look at literature, there's a 2% risk of bleeding in the brain. Doesn't mean you're going to die. Just all the incidents of bleeding, including just incidental finding of the blood on the MRI after the surgery, counts towards the 2%. And so that bleeding, even minimal, counts towards the 2%. Then transient confusion, infection, like in any surgery, has an inherent risk of infection, whether it's appendectomy or gallbladder removal. So there's a potential for infection. Then device-related problems, maybe your battery dies, maybe you get in a car accident and the wire that goes from the head to the chest under the skin gets broken. You need to repair it. So this kind of thing. And you can talk to the surgeon who does it for more detailed list of side effects, because it's surgeon dependent. Let's say if someone is not trained well, they're doing this, they're going to have more side effects as opposed to someone who is the best at this. And we're using one of the best surgeon in the world, Dr. Michael Kaplan at Cornell, who does it. So his probably incidence of bleeding are much, much less than 2%, but I'm giving you average reported number. Okay, so that's DBS. Let's switch gears, talk about MRI-guided ultrasound. I'll tell you which one is better or worse. So this, as the name suggests, it's guided by MRI, and it's ultrasound. So they're not drilling the hole in your brain. They just shave your head completely, put that thing on your, like a helmet on your brain, on your head rather, and map the area, the trajectory where the beam of ultrasound should go. They put you in an MRI machine and then map your brain where this beam should go, and they shoot it. So it takes like 2 hours or so. And then you're awake, you're not, having any pain or anything, and you go home. You get up from that table and you go home. And your tremor gets better by every 85%. In DBS, it's 100%. MRI-guided ultrasound, I've seen 85% improvement. It's not 100%. And you always do it on one side. You can do the second side 6 months later for the ultrasound, but initially just one side. Whereas DBS, you can do it on both sides from day one. And these ultrasound, then the problem is this. is we don't know how long it lasts, meaning how many years. It's relatively new. We've been doing it for like 5 years. So we don't know if 5, 10 years down the road, the tremor will come back. We simply don't know. Whereas DBS, we've been doing for 25 years, and we know that it might come back slightly. And then what I do, I'm going to adjust the stimulation parameters, increase the juice, so to speak, and the battery to stimulate more to keep that tremor at bay. Whereas here, they zap your brain and nothing to adjust. That's it. The question, can you do DBS after that? Nobody knows. Nobody has done it. So I say that if you're older, if you're more frail, let's say you're 90 or you're 85, you don't know, or you don't want to go through the surgery, then probably ultrasound would be better. Generally, we try to do this both with DBS and ultrasound before age of 80, because that cognition, if the cognition is involved, you should not have either of these procedures because you might get demented. So you really need to have your memory checked before we do this procedure. So this is now FDA-approved therapy for Parkinson's disease and covered by insurances, but also could be used for the benign essential tremor. In fact, it was first initiated for benign essential tremor. And there is no risk of infection. However, the bleeding, remember I mentioned the bleeding in DBS, is as identical 2% risk of bleeding from that procedure. You're going to ask why. And the reason why is because the deep portion of the brain are filled with blood vessels. And when they shoot the beam of the ultrasound, they try to avoid the big blood vessels, but they can shoot the small one and it will pop. And there is a still 2% risk of bleeding, even having that ultrasound procedure done, even though they don't even cut your skin and do everything through the skull. But you should be aware that the risk of bleeding is exactly the same as deep brain stimulation surgery. Okay, now let's switch gears and talk about promising clinical trials and stuff that's cooking in the research. I'm not going to talk about stuff that is in the lab, that's in the bench, that's in the early stage, because the hundreds and thousands of initial projects are being done. We will concentrate on late stage clinical trials that have higher chances of getting approved. Let's start with symptomatic therapies, and then we'll talk about disease-modifying therapies. The difference between the two is such that levodopa, it gives you improvement in symptoms, but it does nothing to slow down disease progression. So we call it symptomatic therapy. If, let's say, you took a medication and it didn't improve your symptoms immediately, but you know that it stops progression of Parkinson, and 5 years down the road, you're not going to be any worse than you are now. So that's called neuroprotective or disease-modifying therapy. And we'll talk about that as well. But let's talk about symptomatic therapy first. What are the new medications that will be coming up? Tavadoron. Tavadoron is a new dopamine agonist. We didn't mention that class of medication because no new medications came out recently, but the latest one, probably NeuroPro patch. You might have heard of the patch called NeuroPro, or same class of medication called Rapinarole, Pramipexole. These are all dopamine agonists. So what do? They stimulate your brain to kind of mimic dopamine. They stimulate these dopamine agonists and that allow for the movements to occur. They're not as strong as carbidopa, levodopa. Carbidopa, levodopa is the strongest medication from all the other classes that we talked about. I'm not just saying a regular carbidopa, levodopa. I'm talking about generally, including Rytary, including Crexont. So they are stronger than the enhancers and stronger than Tavadoron. So the difference in Tavadoron from that patch and from the other two is that they stimulate partially D1, D5 receptor, not D2. And in doing so, they achieve same efficacy, but they have less side effects. Because people usually, who take dopamine agonists, they might have hallucinations, they might have impulse control problems, like 17% people develop impulse control problems when they gamble and they shop uncontrollably and so forth. So these presumably would have less amount of side effects with the same efficacy. And there are 3 trials that, this phase 1, phase 2 already took place. The phase 3 already, one of them finished, the 2 more to go, and I'll show you the data. It was just presented in October at the Movement Disorder Society in Philadelphia. I attended. So the trials called Tempo 1, 2, and 3. So the Tempo 1 trial showed reduction in UPDRS, this is United Parkinson Disease Rating Scale. That's how we rate the symptoms. So 10 points less than placebo, which is great because the higher the points, the worse you are. So it dropped the score by 10 points, which is great. Then Tempo 2 is still ongoing, and Tempo 3 was just published. So what they showed here is they had 1 hour, so 1.7 hour day increase in on time comparing to 0.6 hour for placebo. Remember, I told you that no matter what, all these enhancers give you 1 extra hour per day. And the same thing here. You see the difference between 1.7 and 0.6 is like 1.1 hour, because we always want to compare to placebo. And that's essentially what it showed. The side effects included nausea, 14% versus 4% placebo, dyskinesia and voluntary body movements, 10%, dizziness, 17%, some headache, orthostatic drops of blood pressure, 6%, and visual hallucinations we're seen in 5.6%. So not side effect free. I mean, these are the side effects. So it's not like no side effects, but this is the new medication I'm just reporting to you. They're still waiting for the results from the Tempo 2 trial. And there will be one more trial, the extended, the open label extension trial, 1 year long study. So that's in phase 3. So if the study comes back positive, like the other two, probably will be approved, but you have to be aware that the side effects are still will be there, probably somewhat less than existing medications, but still there. So now let's talk about gene therapy. Voyager is the name of the company that does it. And so remember I showed you that map where it says that in the brain, levodopa has to convert into dopamine. So then it's done through an enzyme called AADC. So that enzyme converts levodopa to dopamine in the brain. So this AADC is governed by the gene called DDC. And so what that company did, they created a gene therapy that is injected through the veins, and it basically delivers that DCC gene that contains instructions for making that enzyme called AADC. So actually, in fact, I misspoke. It's through the surgeon. They drill a hole in the brain. It's like DBS type of thing. And through that long needle, they just inject that medication into the putamen, into the brain. And so what it does, it doesn't cure the patients for Parkinson, but it allows for more dopamine to be made from existing levodopa. So it is symptomatic therapy, even though it's a gene therapy. It's like another version of DBS, but like a one-time deal. That's why I tell you, why don't we combine it together? Those people who get DBS might as well, they get in their head drilled anyway, so they might as well put the needle, inject that thing first, the gene therapy, and then put the electrode in the same spot. It's easier, and you get two therapies at once. But that has not been tried yet. So that trial is ongoing for those who are interested. So that's it for the new medications that for symptoms, the design for symptoms. That worth your time. There are a bunch of others that are being developed that I'm not going to even talk about them because it's baloney. It's just pure money making. They're trying to, make money, but I'm not going to discuss these issues that make no sense of doing. Okay, disease modifying therapies, none exist, but a lot of interesting things going on. Before we talk about disease modifying therapy, let me just say that these are the different processes that take place in neurodegenerative cascade. So these are processes that lead to neurodegeneration. And that includes mitochondrial dysfunction, misfolded alpha-synuclein, neuroinflammation, and these processes are interlinked. And so they all eventually lead to neurodegeneration. And so what I'm going to show you is the projects that are designed to address one area of that chain versus another. And I'll tell you what I think about it. So alpha-synuclein removal. So this is the misfolded alpha-synuclein that leads to neurodegeneration. So Biogen and Roche had their trials, failed after phase 2. UCB is another Belgian company. They just finished phase 2. They haven't announced the results. They're planning to do phase 3 clinical trial. So I probably succeeded, but they haven't published the results. I was a sub-investigator on that trial as well, but not in Roche and Biogen. I didn't participate. So then LRRK2 inhibitor. LRRK2 inhibitor has to do with neuroinflammation because that gene, when mutated, can cause increased inflammation in the brain. So there were two studies, Biogen and Denali. These are two companies. They completed phase 1 and they decided to join forces and put the product together, study product together. It's called LUMA trial. Now it's a phase 2 trial. It's recruiting at Cornell and other sites. It's for drug-naive patients, for Parkinson's disease patients who have not taken any drugs yet, who have very early stage, and they essentially give that medication that reduces LRRK2, and they monitor them for probably a year or two and see if they progress or not. It's called LUMA trial. You can look it up. It's available at Cornell in New York. So that's the LRRK2 inhibitor. Now, the other thing is the diabetic drugs. You might have heard of GLP-1 agonist. Example is Ozempic, right? The problem with Ozempic, it doesn't get to the brain. It doesn't. So the other representative from that class, so-called exenatide and lixisenatide, they actually do get to the brain and they show good results. This is the trial, from JAMA, the study showing the improvement in UPDRS on exenatide versus placebo. And you see that there is a clear separation, motor symptom improvement after we're talking about week 60 weeks. So over a year, there was a clear, significant improvement in motor scores, patients who were taking that exenatide. It's subcutaneous injection once a week. Why? Because these GLP-1 agonists, it works on several inflammation, and it improves mitochondrial function as well. The two things. And it reduces insulin sensitivity as well. So that showed good results, but people had some side effects. The newest paper just came out of New England Journal of Medicine in Europe. That medication is available, called lixisenatide. And that's showed that after 12 months, there was no progression whatsoever. People who were taking that medication for diabetes, but they didn't have diabetes, they took it for Parkinson's disease in clinical trial, had zero progression after 1 year. Those who took placebo progressed by 3 points in the UPDRS, which is the average progression, 3 points per year. That's what happened. And they stopped progression. They only measured it for 1 year. I don't know what would have happened later on. But these are exciting things. So those of you who have diabetes, this medication is not available in the United States, but exenatide is available. You can talk to your endocrinologist, asking them maybe they can put you on that one, because it is FDA approved for diabetes. And theoretically, it could kill 2 birds in one stone. I would not recommend the medication for Parkinson for those people who don't have diabetes, because it's not approved for Parkinson. It's in clinical trials. It's not safe. It's not appropriate for you to be taking this off-label, because you can get a lot of weight loss. You can get nausea, gastrointestinal issues. In fact, these people who take lixisenatide, 46% of them develop gastrointestinal side effects. So these are all work in development. Doesn't mean that everybody should jump on that medication. Just be aware the experimental medication should be tried in experimental settings, such as clinical trials. Stem cells, there is one trial available in phase 1 at Cornell. 2 of my patients participated in that trial. 1 patient had seizures after that. It's basically through the brain. They inject the special stem cells that result in, ideally, in slowing down disease progression. And these are the dopamine stem cells, and presumably it would slow down disease progression. We don't know yet. So the study measures, evaluates people over 5 years or so. But that requires neurosurgery, because they inject it to your brain. That's stem cells. And then going back to the diagram, what I was alluding to, saying that I'll tell you what I think about this, is that addressing any one process, they're equally important, but addressing one process is not going to cut it, because look, if you're addressing neuroinflammation, how are you addressing mitochondrial dysfunction? How are you addressing bisphosphoryl alpha-synuclein? You really have to have a combination therapy that is able to combine effect, provide simultaneous effect on multiple targets in order to achieve clinically significant neuroprotective effect. And that's what I've been advocating all along, and I've done some research on that. So people will be coming out later this month about one of the projects I'm doing. So, but that's just sort of, I think that's what the future holds, is to have a combination therapy. And that's what I just said, that if you combine 2 to 3 drugs that are able to address at least neuroinflammation, alpha-synuclein accumulation, and mitochondrial dysfunction, that would be great. Okay, now exercise. Exercise is very important, and combination therapy applies not only to multiple drugs, but also applies to approach to treatment of Parkinson's disease, meaning pills only do half the work. The other half is up to you and up to your physical therapist to really, provide appropriate exercise program, because exercise is the only thing that's proven to slow down disease progression. Yes, they studied it in humans and in animal models. It does slow progression if you have appropriate exercise model. So with this in mind, I want to have Karen Ganelli, who is actually a very well-known physical therapist specializing in Parkinson's disease, say a few words about her approach to treating patients with Parkinson's disease. She's welcome to talk about dystonia as well, but Parkinson's disease, because it's so, so much spoken about. So Karen Ganelli has a doctorate degree in physical therapy specializing in Parkinson's disease, and I will advance slides for her. So I will let her take over from now, and we'll come back talking about after she's done, continue our presentation. So Karen, nice to have you here, and please go ahead.
Okay, great. So thank you, Dr. Shtilbans, for having me. And I want to speak briefly on the importance of exercise and making it a part of your daily routine. Like Dr. Shtilbans said, I did receive my doctorate in physical therapy. And when I was in school, I did specialize in neurological physical therapy, rehabilitation. And I spent many months in a Parkinson's disease treatment center in Nassau County, Long Island. And I've done a lot of research and literature reviews pertaining to Parkinson's disease. So this is my overview summary of the importance of exercise. Okay, next slide.
Yes, you have a lot of slides, so just tell me.
Yeah, I'll go. So there are dozens, if not hundreds, of studies done on the effects of multiple modes of exercise on the symptoms of Parkinson's disease. They have studied anything from yoga to weight training to cardiovascular. Any sort of exercise has been studied. And the good news is that everything is effective. So based on an overview of 39 trials that were deemed very relevant, exercise has been shown to improve gait speed, endurance, decrease freezing episodes, increase functional mobility, improve balance, and decrease functional disability. So because everything is proven to help, what exercise is the best? And there was a review of 43 randomized clinical trials, and the review was trying to see what is the most effective type of exercise. If someone could dedicate an hour a day to exercise, what would they pick to be most effective? And unfortunately, there was no good studies that did one exercise versus another and showed more improvement in that genre versus another. Me personally, as someone with almost 20 years of experience working with people diagnosed with Parkinson's, I could tell you if you had to start somewhere, it would be with a cardio routine. Next. So what exercises will you do in physical therapy? You will do aerobic activity. That's where I always start off. Do you have a gym available to you? Do you have equipment at home available to you? Strength training is going to happen at the gym that you're going to with physical therapy, or even just table exercises. You're going to get gait training if necessary, and then balance training. So aerobic activity, most important thing. This can be done using a bicycle, which has been shown to be very effective, 45 minutes a week, 3 times a week, and you want to pump pretty hard, 80 to 90 revolutions per minute. Now, before starting any aerobic activity program, you do want to be cleared by your internist for your heart. So if you're ever feeling short of breath, dizzy, chest pain, you want to stop immediately, even if you are cleared. But in your regular physical, you can let your physician know that you are exercising and you do want to be cleared on an annual basis. So there has been studies done on aerobic activity for the past 30 years, or more. Treadmill training is very effective. Tai Chi is effective. Speed walking, dancing, boxing, biking, everything. So you and your physical therapist will come up with something that is going to keep you motivated and keep you compliant with the program. Okay, so this particular activity, this aerobic activity, is called the TheraCycle. If anyone just wants to see some uplifting data, this study was done on the TheraCycle, I want to say 10, 15 years ago, but this bike is activating and initiating motion of the legs. And you are doing all of the work, but it's initiating it. So you're getting a lot of revolutions per minute. This bike is really safe in a way that it's easy to get on and off, limits the risk of falls. People that are wheelchair bound can even do that with different models. Do this bike with different models. This bike, oh, you could go to the next slide, Alex. That bike, nope, I'm just going to tell you, did research. They did research on this bike. In 6 weeks, that was it, using this bike, 40 minutes a day, 3 days a week, there were people ranging from 40 to 60% improved in just 6 weeks. So it's a quick result. Next thing is strength training. Strength training can be anything from free weights to TheraBands to body resistance, say push-ups, or whatever you feel is stressing out your muscles. You want to progress your resistance over time. So that's why resistance exercises are called progressive resistance exercise. It has been shown in dozens of studies to improve strength and physical performance in people with mild to moderate Parkinson's disease. Okay, next thing is LSVT big. And I don't know if anyone has practiced this mode of activity or therapeutic exercise, but it's very popular, especially with patients that are mild to moderate degrees of symptoms. And it's just called LSVT because Lee Silverman happened to be the first patient to receive this type of therapy. It started off with voice treatments and how to project your voice, and it ended up with think big with movements. So this is a very specific set of a dozen exercises that are to be done for 40 minutes, or not even 40 minutes, about 20 minutes, 4 days a week for a 6-week straight time frame. That's how the study was modeled. The study showed significant improvement in all gait, balance, strength, everything, in all of their outcome measures. So LSVT is a really good way to kick off physical therapy. You should ask your physical therapist if they are knowledgeable pertaining to LSVT. This is some examples of some exercises. So everything is exaggerated. When you reach out to the side, you go all the way out. When you reach up, you reach all the way up to your max potential. And in your mind, you're thinking, I need to exaggerate. I need to think big. Gait training can be done effectively on the treadmill, although I do not encourage that because of fall risk. But there has been several studies showing that there was significant improvements in gait speed, endurance, and stride length, treadmill training for just 1 hour, 3 times a week. And also that had a follow-up of continued improved gait endurance for a year after that. So walking is good. I don't particularly use it as a mode of cardio for my patients due to the fall risk, but it is good if you are safe and able to do so. So speaking of fall prevention, that is most of my patients' biggest concerns. I'm scared of falling. And what helps you prevent falls? So another bit of good news, exercise in general helps you prevent falls. Cardio activity, strength training, all of it helps you prevent falls. So whether it's a study that showed leg muscle strengthening. It did help prevent falls. It helps with, just basically repeated movements, functional activity training helps prevent falls. So another reason to partake in physical therapy and exercise. So the results of most of the studies showed that post-intervention, so after you're done with like a 6-week or 3-month exercise intervention, exercise groups always scored significantly better than control groups when studying functional independence, sit-to-stand test, fear of falling, and quality of life. So other things you can do to prevent falls are to make sure that you're minimizing your risk of slip and falls. The bathroom is a common place to fall for my patients. So here are just some examples of different assistive devices that can minimize your risk of slip and falls. Getting in and out of the tub sitting down as opposed to standing. Using grab bars in the bathroom, and especially the shower. And then raising the toilet seat 4 inches and having a toilet seat with handrails on it to assist you in sit to stand, so you're not doing that intense momentum forward flexion move that can lead to overexertion forward and a fall. Here are some gait-assisted devices. Walkers, rollators, loft strands, all of these things can prevent falls. I think we're almost done.
I added a U-step walker for you.
The U-step walker is specifically for the Parkinson's population. And the next slide, there's something else. The laser cane, which acts as a visual cue, is also specifically for the Parkinson's population. I like the hurricane because it's a tripod cane that actually moves in every degree to accommodate for uneven terrain, which New York City has plenty of. So what do you do now with all this information? You know that every form of exercise helps you. Make sure you're medically cleared, get a prescription for physical therapy, find a physical therapist that works with patients currently and is up to date on the literature with Parkinson's disease. Come armed with knowledge, bring this presentation if you need to, read up on what you're doing, stay motivated, get support because compliance is key.
That leads us to the combination therapy sort of model that I was alluding to earlier, having not only movement disorder neurologist at your side, but also other providers that could be good, members of the multidisciplinary team. And in fact, you really need to have multiple experts in different areas of medicine to work together to address issues related to Parkinson's disease. So movement disorder neurologist like me is just one of the providers, but you really need physical therapists like Karen. You need occupational therapists. You need nutritionists to make sure you're taking your nutrition is optimized. You need sometimes speech therapists also, as well as a general practitioner. So we can discuss with them your medical issues that might or might not be related to your Parkinson's disease. So psychologists, psychiatrists could be helpful as well because of the high incidence of depression and anxiety in patients with Parkinson's disease. Those who undergo certain neurosurgical treatments such as DBS or ultrasound therapy need to have access to neurosurgical specialists, and a social worker also very important. For reasons that are obvious. So, and the patient is just there. So what we need to do is to create multidisciplinary approach to treatment of these patients. And this is not just my idea. I mean, that's been published widely in the literature. Like, look at this paper in the Journal of Neurotransmission, Breaking Barriers in Parkinson's disease care. They discussed the multidisciplinary team approach and found it to be very helpful. Now, there is even international consensus statement on multidisciplinary rehabilitation care in Parkinson's disease, also advocating for that. And another paper in Journal of Neurotransmission came about this year, discussing the very important role of multidisciplinary care in Parkinson's disease patients. But guess what? It's not available. And the reason for that is multifold. People are pulling, they're really not willing to play in sandbox. there's not enough funding to allow for these models. And because insurance doesn't reimburse for certain things that you really need to have that coverage. So what's been happening, and I'll walk you through this model, is the parallel practice. When you go to see a neurologist or for Parkinson's disease in private practice, you get parallel practice. What is this? Healthcare professionals operate independently, providing care based on their specific expertise. Minimal, it's no interaction among other team members. There are no team members, period. Then consultative practice. When you go to academic centers, you get professional neurologists that specialize in movement disorders. They give you their advice, but they only consult in so to speak. And you really need to have a manager, like a primary care doctor in Parkinson's disease, that your movement disorder neurologist would be and should be, instead of just a consultant. So then the next step is collaborative care. Collaborative practice. It's a more interactive model where professionals share information and plan together, ensure that they have cohesive management plan for the patient. But it's still not where we should be. I believe that's where I am right now, as a collaborative practice. The next level will be coordinated practice, where care is organized. I tell you, you go see nutritionist there, you go see your physical therapy there, you go see the social worker there. I don't have yet, for the reasons I mentioned, mostly logistical reasons, the access to these providers at my fingertips, but that would be the ideal. Then multidisciplinary care, where I would like to be, and that's where each member addresses patient care from their professional perspective, working in concert, but often without direct interaction. So let's say they're in different offices, but I send you to another office, and then I call them, I get their notes, we discuss, and get back to you. Then that's the multidisciplinary care that I think is doable, and that's what I want to develop. But then if we go further, then we have one big office, and we have every therapist in place, and they see one after another, after another, after another. Then we sit around the big table and discuss you. And everybody is there. That's interdisciplinary practice. That's the ideal. But it's logistically impossible to bring every specialist at the same time to round table for every single patient you see, because I have to see many patients. I mean, I cannot afford to just see 3 patients a day, obviously, or 5 patients a day. So that, and integrative practice, it means that it's a holistic therapy where you have addressing the medical issues as well as psychological issues, nutritional issues, all of them. So I think the multidisciplinary practice, it's a realistic goal. So now let's switch gears and talk about benign essential tremor. So benign essential tremor, there's no new medication for it. We talk about propranolol, primidone, Topamax. These are 3 medications that have been around for ages. There's a new clinical trial that I would like to tell you about. It's sponsored by Praxis, and I'm one of the lead principal investigator for the country. It's 20 sites in the country, and it studies a new medication called Ulixa, and it basically measures improvement in the benign essential tremor over a 12-week period. So it's a 3-month trial, and it's a phase 3 trial already. Basically, the medication is the mechanism of action is a T-type calcium channel blocker, and it is currently in the phase 3 development for benign essential tremor. It's a highly specific type calcium channel blocker, and what it does, it blocks abnormal neuronal burst firing in the cerebellum. Cerebellum is a big part of the brain that's responsible for the motor control, and when it's impaired, people have involuntary body movements. So this medication blocks this abnormal bursting activity and stabilizes the motor control. Basically, the 3 parts of that trial. The total 600 subjects have been recruited. The first 2 are 12-week study, and the third study is the open-label extension trial that takes place over a 1-year period. So those people who did well or who want to continue taking the medication are able to do so by enrolling that extension 1-year-long study. But the initial one, it's a 12-week study. You take the medication once a day, and you can stay on your existing medications Those of you who are taking propranolol or Topamax, Topiramate, you can stay on that. Primidone is not allowed. So if you're taking primidone, they would want you to stop primidone to participate in this trial. So phase 1 and phase 2 were safe and encouraging. So they're doing phase 3. They will the recruitment will end in January of 2025, and they expect to finish the last patient in May of next year. So we'll have results next fall. We'll have the results of that study, and if it's positive, it will be approved. So we'll see. Just letting you know, if you're interested in that trial, it's Essential 3. You see, like Essential Tremor. So you can Google Essential number 3. And you will get to the website of that trial. You can register. The beauty of this trial is that it's decentralized, meaning you don't need to go anywhere. They come to your house, they give you the study medication, and the visits with the doctor are done through the Zoom, like I'm talking to you. So that it will be both ways. So you can voice your issues, what you have, you can answer questions, and they will examine you through the camera. So you don't need to leave the comfort of your home. And it's only 3 months long study, if you're interested. Switching gears, so that's benign essential tremor. Switching gears to talk about dystonia. There is one new medication that you should know about, botulinum toxin, Botox. So those of you who have dystonia and who have been receiving Botox, you know that it only lasts 2 months, 2.5 months, but insurance only allows you to get injected every 3 months. So for the last 2 weeks, at least, you suffer. And there's a new long-acting Botox available made by a different company. It's called Doxify. And that Doxify, it lasts much longer. So basically 16 to 17 weeks median time to reinjection as opposed to 12. So, but insurance companies allow you still to get it every 3 months, but it lasts in reality 4 months. So there would be no wearing offs between the doses. So no roller coaster like we have had with Botox injections. So it's a novel formulation of botulinum toxin that has property of long-acting medication, and it lasts longer. So the data from clinical trials I'm presenting here, I'm just showing to you, it's been published already, it's not new. So basically, these are the numbers on this horizontal line. These are the amount of weeks, how many weeks. And this is the effectiveness of the agent, of that Doxify, that Botox, long-acting Botox. And you see the regular one, usually it's effective for like only 10 weeks or so. But here, it's 100%, 12 weeks, like 100%. And then the reinjections, average reinjections were occurring around 75%, so like 16 weeks. So the median duration in weeks were for the dose of 125 units, 20 weeks. For 250, the duration was 24 weeks, so much longer than for Botox. And you can get reinjected as early as week 12. The insurance would allow you to get reinjected, even though it might continue to last significantly longer, up to 16 weeks, definitely. So and that's commercially available. I just need to have the hospital establish the account with that company so we can purchase that. I have not been able to do that yet. Once it's available here, I'll be able to inject for those who have dystonia that is approved officially for cervical dystonia, but eventually they'll get indication for other types of dystonia, for spasticity, for blepharospasms, for facial spasms. Right now, it's only approved for wrinkles, but I don't do that. And for the cervical dystonia, which I certainly manage, and will be able to use it as soon as I have it here, but it's already commercially available medication. So that concludes that, because there are no oral medications, not even close in development, that there are some oral anticholinergic medications they're developing in early stages, but it's not near the end of the development, so I'm not going to talk about those. But right now, this is already in existence. You should know about it. It's called Doxify for those of you who have cervical dystonia. So that concludes the presentation about the advancement. But last slide in terms of how to find clinical trials. So what a reliable way. Obviously, ask me. As your neurologist, I'm happy to guide you. But general rule of thumb: if you have Parkinson, the Parkinson Study Group or Fox Trial Finder is excellent. So two excellent sources for clinical trials. for Parkinson's disease. More general sources include clinicaltrials.gov or Central Watch. There, it's for any condition, whether it is neurological or this could be for cancer or what have you. You just go on that website, type the indication, Parkinson's disease, type your zip code, the distance from the zip code, how far you're willing to travel, and what phase of the study you want to do, phase 3, the late phase. And then it will give you, that's a filter, and it will give you the list of the trials according to that filter. And you can then contact people, the contact information will be depicted, and you can reach out and see if you qualify. So that's more general, but Focused Trial Finder and Parkinson's specifically for Parkinson's disease. And nonetheless, these are good sources, but I remain to be sort of a best source in terms of I'll be able to advise you specifically pertinent to your condition, to your state of the disease, which trial would be best suited for you. So definitely use this databases, find interesting trials that you want to ask me about, and ask me, and I'll be able to tell you, in more details about them. So I do thank you for participation in today's lecture.